will introduce. Our next speaker is, this is going to be fine, is Dr. Sonia Nishtar. So Dr. Nishtar is an internationally acclaimed Pakistani physician and a public health expert. She currently co-chairs the WHO High-Level Commission on Non-Communicable Diseases, along with the presidents of Finland and Sri Lanka. She also co-chairs the World Economic Forum's Global Agendas Council on the Future of Healthcare and the U.S. National Academy of Sciences Global Study on the Quality of Healthcare in Low and Middle Income Countries. In addition, she also chairs the UN International Institutes for Global Health Advisory Committee. She is the founder and the president of the NGO Heartfire in Pakistan, and previously served as a federal minister in the Pakistan government in 2013. Sonia was nominated Pakistan's nominee for the Director General of the World Health Organization in 2017 and was in the final shortlist for the three. Earlier, she was the founding chair of the UN Secretary General's Independent Accounting Panel for Pakistan, Panel for Women's and Children's Health, and chaired the WHO's Commission on Ending Childhood Obesity. She has received many international awards for her work and is widely published. She graduated from Khawar Medical University. Was the best graduate in 1986. She's a fellow of the Royal College of Physicians and took a PhD at the King's College. Sonia is just actually was at the third UN high-level meeting, is just returning from there and will be just got off a flight, and I'm very grateful that she agreed to be at this meeting to discuss with us coping with NCDs, implementing recommendations of the UN high-level meeting on NCDs, low and middle-income countries. So, Dr. Nishtar, please.
Well, good morning, everyone, and thank you, Tazeen, for that kind introduction. Are you able to hear my voice? Okay, well, first of all, let me begin by apologizing for not being there in person. I would have delighted to have been amongst you and to have learned from all of you and to capitalize on sharing of experiences, but I've just landed about half an hour ago, and it was not possible to reschedule flights. I just spent an exciting 1 week in New York, attending several meetings on the margins of the UN, the 73rd UN General Assembly. And relevant to our scope of work, the most salient event there, as you know, was the third high-level meeting on non-communicable diseases. This was in fact a summit attended by several heads of state. If we go back in history, I'm sure you would recognize that the third high-level meeting follows the first one in 2011, which is where we actually started to turn the corner in relation to NCDs, when the 2011 political declaration actually set the stage for the inclusion of NCDs in the SDG framework. The 2011 political declaration was the outcome of the first high-level meeting, which was signed off by several member states, and 34 heads of state attended it personally. This was followed by the second high-level meeting in 2014, which reaffirmed the commitments of 2011 and laid additional emphasis. Subsequent to that, in 2015, as you all know, non-communicable diseases were integrated into the framework of the Sustainable Development Goals. Goal 3 centers on health, and within that framework, target 3.4 relates specifically to non-communicable diseases. And since then, there has been somewhat an accelerated momentum towards the achievement of that target. And some level of emphasis on non-communicable diseases, which, as you know, was completely missing in the era of the Millennium Development Goals. This is for very good reason, because we know that non-communicable diseases are the biggest global killers. They cause 41 million deaths. The massive suffering is not just in human, but also in economic terms. And we know that even after the political declaration of 2011 and of 2014, the progress has been abysmal. Recently, the World Health Organization published its the status of country implementation of commitments in its monitoring report of 2017. And the progress was dangerously slow. More recently, the Lancet Countdown has also, which was a mechanism of independent accountability, has also told us that we are seriously off track, and unless an accelerated input is given, the world is not going to be able to meet the commitments we have made. So within this overall framework, this meeting was very important to renew commitments, to emphasize the importance of some salient areas, which I will come to in a minute, and then to make a call for specifically for integrating NCDs with universal health coverage. Now, the World Health Organization and the allied multilateral agencies have done remarkably well in terms of setting the norms and standards, in terms of developing the targets, the framework of surveillance. They have articulated the global strategy. They have achieved a global consensus around that. The targets and indicators and the monitoring frameworks, and all the tools are implementation tools with reference to those have been established, and it is absolutely imperative that we get the momentum up and running on ground. The work that you are doing here today, and the work of COBRA in particular, is extremely important for a number of reasons in relation to the bigger picture thinking. Firstly, because there's an explicit call for the integration of NCDs into universal health coverage. This was not clearly mentioned in the political declaration, but the High-Level Commission on Non-Communicable Diseases, as you all know, has this very much as an explicit recommendation. And all the events that took place on the margins of the high-level meeting and on the margins of the UN General Assembly, whether it was around cancer or food systems, or whether it was cardiovascular disease, or the several events around chronic lung conditions and diabetes, clearly signal the technical and the political communities, notwithstanding the explicit mention of this in the political declaration, clearly indicated that integration of NCDs is absolutely critical into the framework of universal health coverage. In fact, our commission has gone as far as saying that it would be a tragic missed opportunity if current efforts aimed at institutionalizing universal health coverage failed to integrate the world's leading killers. We could actually end up undermining the economic case for universal health coverage. Next year, there will be a high-level meeting on universal health coverage, where heads of states will again come together, and our commission is already putting together the normative tools to ensure that we influence that process effectively. Of course, when we talk about integrating NCDs into universal health coverage, we need to provide we need to be clear on the specifics. And that is where the integration of NCDs into primary health care becomes very important. Again, there is a lot of emphasis on that explicitly within the political declaration and outside of that as well. And that is where your work is hugely important. Your work is also very important because there is a move globally from the overall basket best buys approach to prioritization within the framework of NCDs. As you all know, that the best buys and the good buys of the World Health Organization, which have very much been at the forefront of influencing development priorities within the framework of NCDs, is a long list. It's a list of 54 interventions. And we all know that if we are to achieve target 3.4 of the Sustainable Development Goals, we will have to push a few hot buttons and pick on a few key interventions which have the impact, which have the potential of reducing mortality. And tackling blood pressure, certainly, as you know much better than I, is clearly deserves to be the #1 priority, which is why the work that you're doing in terms of bringing key evidence to the table is such a salient effort at this point in time. As you're well aware, primary healthcare systems all over the developing countries have been oriented towards infectious disease control, towards maternal and child health. It is only in certain pockets, for instance, in certain parts of sub-Saharan Africa and other parts of developing countries, that owing to the efforts of initiatives such as the Global Funds for AIDS, TB, and Malaria, and PEPFAR, that the chronic care systems have been developed to cater to the needs of the long-term needs of management of diseases like tuberculosis and HIV and AIDS. And even today, if you go into such settings and you see two women sitting in the same clinic, the one who's going to open the door and go to the HIV clinic will have all the upstream and downstream tools and systems to navigate her through her chronic condition. But if another woman sitting in the same room opens the door and goes to the diabetic clinic, we will have antiquated systems with absolutely no capacity to deal with whatever is required to manage her condition effectively. And it's the same for treatment of high blood pressure. So the work that you're doing to illustrate how the management of blood pressure and high blood pressure and other chronic conditions can be integrated with primary health care, with the work of community health workers in particular, is of immense value at this point in time. There is no controversy over the integration of NCDs into the work stream of community health workers anywhere. I'm sure you know that when it comes to the integration of NCDs into universal healthcare, there are a number of polarized discussions at the member state level on what and what should not be espoused as an overarching policy goal. But when it comes to primary healthcare, to community health workers, there is absolutely no controversy. So just repeating myself, but this is to emphasize the importance of work you do. We really look forward to the evidence that will come to the table from your work, and to find ways and means of integrating it and upscaling that. So for now, I'm just going to stop because I know that you want me to interact with the audience and the other experts at the panel to be available for that. Thank you very much.
So hello, Sanya. This is Richard Smith. Can you see me? Yes, I think I can.
Hi, Richard.
Hello.
Yes,
so
Richard, I can see you.
I'm going to moderate this discussion, and perhaps I could start by asking you. You talked about things being dangerously slow and seriously behind schedule. You didn't quite make it clear when you came away from the high-level meeting whether you thought that's all going to change, whether we are going to go faster now.
Well, that's a very good question. I have no option but to be optimistic. Let's put it that way, because if you look at the track record, very little changed after the 2011 meeting and the 2014 meeting, except for an increase in awareness. Now, when I say very little changed, I mean in terms of prioritization at the global level. Because if you look back in history, whenever we have seen change cascade into tangible outcomes, there have been three variables consistently at play. The global community rallies together, puts a clear strategy, culls adequate financing and gives it and has a clear institutional arrangement at a global level. Now that has been missing for non-communicable diseases. But in the NCD space, we see a very interesting dynamic. And I hope that you were following the report backs and the statements by countries at the high-level meeting. I mean, despite the lack of appropriate impetus by the international community, we heard Trinidad saying that they were borrowing from the World Bank. We heard from Argentina saying that they were doing likewise. Many countries in the world reported that they had made significant progress in levying a tax on sugar-sweetened beverages, that they were aware on what needed to be done in terms of tobacco control, and that they were rallying together a range of actors and developing multi-stakeholder mechanisms to to influence the trade minister and the commerce minister and the finance minister. And a number of countries actually talked about the discourse underway to integrate NCDs into the work plan of community health workers, to step up PHC readiness. So we see a very interesting dynamic at play. A global community which is loath to the idea of putting a global fund, and I'm not saying by any means that the vertical approach is the right way to go. But that notwithstanding, a global community that has no intention of putting together a global fund, has no intention of stepping up, signaling priority, but a lot of action is happening at the country level. And if you look, Richard, at the country demands which have been articulated very clearly in the country cooperation strategy paper, which is in the public domain of the World Health Organization, their number one ask is for technical assistance to step up NCD prevention and control. Their number one ask is that. But on the other hand, if you look at the budgetary allocations, evidence of the priorities that WHO gives to this, they are completely at the other end. Now, I don't want to hold a WHO responsible for that and the World Bank responsible for that, because it is ultimately the donor countries who earmark monies very narrowly. So I think at the barest minimum, what we can do is to ease up that space, without creating a global fund or another international instrument. And in fact, if you look at the recommendations of the High-Level Commission on NCDs, that's the first recommendation we've made. That WHO should prioritize NCDs before we ask countries to do that, because they're shouting at you. They're saying this is the help that we need because we are doing A, B, C, X, Y, Z, and we heard that firsthand during the high-level meeting. I mean, when I went to countries and spoke to heads of state, finance ministers, and not just health ministers, as a candidate for WHO DG, and I went to 70 countries, that was their number one ask. That if you were the DG, what would you do for NCD? So there's a long-winded answer to your very important question. Yes, we have no choice but to be optimistic. Yes, the impetus to independent accountability, which I think the credit of which the Commission should take to a very large extent, and thanks to Richard for coming up with a timely report, will hold the actors accountable. But we need to do a few things at the global level to be catalytic, and I applaud countries for charging ahead with progress despite the lack of international impetus.
Good, thank you very much. I remember learning years ago, don't look at people's strategies, look at their funding, where they spend their money. Questions?
Yes,
this is a tremendous opportunity to question Sania here. Well, here we are. Tell her who you are.
Well,
the camera's over there.
hello, Senator. I'm Deepika from Sweden, Professor of Health Sciences. Given the fact that the increase of childhood obesity goes even faster than the increase among adults, I would like to know, was there any special interest in tackling the childhood obesity problem at this meeting in New York?
Yes, thank you very much for that important question. We actually had one of the 4 key side events on childhood obesity, on the margins of the high-level meeting. And that side event was sponsored by the government of Portugal. As you know, Portugal is very much the trailblazer in having established the Childhood Obesity Surveillance Initiative, which is the acronym of which is COSI. And within the WHO Euro office, the COSI surveillance tool has the technical assistance around that has been cascaded to more than 50 countries within Europe, and now their aspiration is to take it global. I'm sure I don't have this to tell this audience that surveillance is the first step to evidence-based and concerted action. And that was a very important session, both from a technical perspective, but also from the political perspective, also from the perspective of signaling the importance of one area. And at that session, the World Obesity Federation unveiled a progress report. That progress report basically went back to 2016 and monitored progress of the implementations of the recommendations of the WHO Commission on Ending Childhood Obesity, which, as you know, was popularly known as ECHO. And I had the honor of co-chairing that commission with Sir Peter Gluckman from New Zealand. Subsequent to the publication of that report, and I'm sure you recall that its recommendations were divided into 2 areas. One, initiatives to tackle the obesogenic environment, and secondly, initiatives along the life course, given the understanding that obesity is a complex multidimensional issue, and that there are very salient developmental and epigenetic influences impacting along the life course. So the recommendations were then cascaded into an implementation plan, which was shared with countries. There was a lot of push to promote implementation. And 3 years down the line, the World Obesity Federation, as an independent entity, conducted an evaluation of what progress had been like. And unfortunately, the situation did not look good. Yes, there was an emphasis on childhood obesity, as it should be. And yes, we had a bittersweet kind of report back with the Childhood Obesity Surveillance Initiative being scaled up and ramped up outside of Europe. But on the other hand, with metrics, objective evidence from metrics telling us that things were not looking good.
Thank you very much.
I must say, oddly enough, Sania, I was editing last night a report on the high-level meeting, which was a bit despondent in a way, but it said that one of the things that was so good were the side meetings where you heard much more than at the first meeting, the voices of patients, of the young, and there was much more talk about children. So that was a sort of optimistic. Now we have presidents of colleges here in Sri Lanka. This is an opportunity to ask Sania something?
Sania, Shanti Mendes here. We miss you. You should have got yourself down here to Colombo. Anyway, my question.
Well,
my question is 2011-2014, we had, in my thinking, few presidents, because we have 194 member states, few heads of state, because at the beginning it was like 30s, 40s, and then 2014 it was more. This time, how many heads of state participated? Was it 194? And I don't think it would have been. And the second question was, did they have any concrete suggestions as to how to get health, transport, agriculture, all these other sectors to collaborate together under their leadership and accountability of these various sectors outside health? Because ministers of health is one thing, but these ministers, WHO has no jurisdiction in these areas at all. Thank you.
So first of all, I want to acknowledge the presence of Shanti in this meeting. I'm sure you all recognize what an important and salient role she has played as coordinator of CVDs in Geneva, and I want to acknowledge my special friendship and affection for her, and recall the times we worked together all over the world. So thank you, Shanti, for all your work. In terms of numerics and heads of state, just prior to the meeting, the expressions of interest that we had were from 54 heads of state. And this clearly surpassed the number. But I don't want to come up with the final number now because we're still tallying and officially documenting, because several of them were represented by the ministers of health. So I would be hesitating in naming a number as of now, but that number will soon be public. In terms of concrete suggestions, well, firstly, I think the political declaration clearly says in its first out of the 13 recommendations that NCDs is not something that can be turned around by the ministers of health, because a lot of times you don't need to convince ministers of health. They know that a tobacco tax needs to be levied and what it would do for mortality and reduction of morbidity. They don't need to be convinced that a tax on sugar-sweetened beverages is immensely valuable. They do not need to be convinced of the value of action around trans fats. But these recommendations, these suggestions, the framing of such bills actually pits them against their other cabinet colleagues. And again, sorry for being a bit self-reflective, but this is just to bring first-hand experience into the room. As candidate, when I would speak to ministers of health, they would tell us, well, you don't have to convince us of the importance of these things, but would you be standing by our side when we would take these proposals to the parliament, because that is where they are shot down. So this is a long-winded way of saying that unless the heads of state get involved to overcome this impasse, we talk about multi-sectoral approaches and intersectoral approaches, but actually these are serious clashes at cabinet meetings. These are impasses that need to be resolved with leadership, and of course heads of state, sensitizing the heads of state, getting them to be involved, getting them to chair interministerial meetings where these decisions are being taken is absolutely crucial, which is why the first recommendation of the political declaration is important. And I'm very humbled to say that the report of the High-Level Commission on NCDs, which basically squarely put this as its first recommendation, was able to, with great humility, I'd like to say, was able to inspire this, and our recommendation was able to cascade into it. In terms of more specifics, you may have heard President Kenyatta speaking about the Multi-Donor Trust Fund. As you know, when our commission recommended a multi-donor trust fund on NCDs, there was a lot of pushback. There was a lot of pushback, especially from the donor governments and the development community, that the days of trust funds are gone, and that the commission should not have brought this ask into the public domain. And we tried, and the commission continued to explain, and we will give this more granularity in the second phase of the commission, that we are not asking for a huge top-down global fund-like fund. What we're asking for is a catalytic fund so that we can handhold countries to implement and to provide technical assistance for something for which they are willing to provide sustainable and sustained domestic resources over a period of time. And I think there's a bit of a joining of the dots to do here. So if the outcomes of the COBRA study and the tools and strategies that emanate from within this work to integrate NCDs with the work of community health workers. There would be some technical assistance required to step that up in countries, and that is what we envisaged the Multi-Donor Trust Fund was for. So President Kenyatta's explicit support for this was hugely important, and as we go through the statements, clearly other specific recommendations, there are also other specific recommendations.
Well, Sanya, thank you very much. I think we're going to have to end there because we're running a bit behind with our meeting, but we're hugely grateful to you. Although we're a little disappointed that you couldn't make it to Colombo, I must say I'm massively impressed that you could have got off a plane half an hour ago and answer questions as cogently as you have. And I think thank you too for your very supportive words about COBRA. So thank you very much, and I'm sure we'd all like to show our appreciation. So you can go to bed now.
Thank you, thank you. I'm honored to join you virtually, and my apologies once again for not being able to be with you in person. Thank you very much. And have a great meeting.
Thank you very much, Sanya. Thank you very much from Sri Lanka.
Thank you. Thank you.
Just a quick reminder. We've been talking about the primary healthcare strategies that we have used to control blood pressure in a rural community. And now we're talking about escalating this and taking to a different level, scaling up, with hopefully diabetes also joining with various strategies. Now, I'm very conscious of the fact that there is Ministry of Health policy level people here, the World Bank, and specialist colleges. You are at the receiving end of the problem. And I think bringing context is very important. If you have any questions to ask about monotherapy, or you want to move towards other levels of therapy, the Ministry of Health is planning a package for managing hypertension and NCDs at the community level. There's a care package being developed. Who has to deliver this? What level of training you want for this? And what level of training should the primary health care, the peripheral hospital doctors should have? I think that's the kind of question that you probably have and would like to ask. And your intervention, your suggestion to include, even at a primary health care level, as a tool to leverage this, to improve hypertension and diabetes control, will be very useful. So all of you are extremely important to this discussion.
Just one word on that. Over the past 10, 12 years, within the European Society of Cardiology, we've been trying to advocate the fact that monotherapy is old-fashioned. You have to see this in a multidimensional total cardiovascular risk method. It's coming, but it takes a long time for our generalist practitioners, even in Sweden, to understand that just treating blood pressure is not enough. If you don't talk about lifestyle first, you miss the boat.
Thank you. So we'll have the next So if we can have the next session, please. I'd like to invite the next session co-chairs now. Professor Kate Hunt and Professor Shah Ibrahim, if you can please come. So And Professor Kate Hunt is from the Institute of Social Marketing, Faculty of Health Sciences and Sport, University of Stirling from Scotland. And her research is focused on understanding and improving human health and well-being with a particular interest in social determinants of health, gender and health behaviors. I'll just give you a brief intro. After completing her interdisciplinary undergraduate studies in human sciences at Oxford, she completed a master's in reproductive epidemiology at Oxford and a PhD in gender and health at University of Glasgow. And she has served on several UK funding agencies and oversight committees, including the UKMRC's Population and Systems Medicine Board, UKMRC's Population Health and Intervention Development Panels, and also the UK Biobank Ethics and Governance Council. She was a trustee of the Foundation of Sociology of Health and Illness, and she serves on our trial steering committee. And Professor Shah Ibrahim is Honorary Professor of Public Health at the London School of Hygiene and Tropical Medicine, and he has held a Wellcome Trust Fellowship in Clinical Epidemiology and trained in primary care, subsequently in geriatric medicine, and chaired geriatric medicine at London and Barts and in clinical epidemiology, and has done epidemiology of aging. He was a visiting fellow at University of Bristol and visiting professor at University College London. It was a co-editor of the International Journal of Epidemiology for the longest. I think he just stopped editing for them last year only. And a coordinating editor of the Cochrane Heart Group. He chaired the Wellcome Trust Population and Public Health Funding Panel Committee, and is the non-executive member of National Institute for Health Sciences and Clinical Excellence, which is nice. And Shah is a collaborator of the COBRA-BPS and also served on the trial steering committee. So you will please co-chair this session, in which I will now invite the country principal investigators to please join the panel. So Dr. Aliya Naheed, who's the country PI from Bangladesh. And I think Dr. Anuradhani will join on behalf of Prof. Asita. And Dr. Imtiaz Jehan from Pakistan. And we'll also have Professor Eric Finkelstein, who's our health economist from Singapore. And what we want now is we'll just have a panel discussion, and each one of the sites will discuss a little bit of the COBRA-BPS strategy has done. I'm sorry?
Imtiaz, don't be shy. Don't be shy. Come on. we can't start unless Pakistan's in the room. Okay, I think the purpose of this panel discussion is not to hear a blow-by-blow account of how the research has been done in each country, but really to focus on the lessons that can be learned from doing research on blood pressure in rural areas of Pakistan, Sri Lanka, and Bangladesh that could be useful for policymakers in terms of implementing a scale-up of NCD programs in each of these countries and in the region more generally. Because it seems to me that, in actual fact, when we do research, the answer to the primary research question that we pose is actually the least important thing that comes out of the research. The side benefits of doing research are finding out about the health system, finding out how things work, what doesn't work, and how to get people to work collaboratively to get things to change. And we've heard from Sanya how basically over the last 15 years, the NCD momentum has stalled. And we're obviously hoping against hope that it won't stall again. And one of the reasons it's stalled is because nationally it's difficult to work out where to begin with such a big problem. And I think what the trials that have been done with COBRA have allowed to happen is to get things to happen in miniature with a view to going forward. So I would like you to make your comments and things in the framework of what would be useful for policymakers from your experiences in conducting the research. So, should we start off this way, Aliya?
Yeah, so you can, I'll coordinate that.
Who needs slides and who doesn't?
I don't need slides.
Why don't you kick off then?
Yeah, so let me just give a couple comments. So I'm a health economist by training, and in fact, I think there's a reality that we need to recognize, and it's that as economies grow and as countries become more wealthy, every one of those countries sees a transition from infectious disease to rising rates of chronic diseases. And so I think Pakistan, Sri Lanka, Bangladesh, we're seeing that transition now, and so we're seeing rapidly rising rates of NCDs, and it's unavoidable. And at the same time, we see rising demands for a healthcare system, so pressures on costs, also unavoidable. Now, the other reality, and I think, Shah, you mentioned this point, is that if you speak to anybody, it doesn't take a PhD. Everybody knows that if you diet and exercise and take your medications as prescribed, you will be healthy, right? So that sounds pretty simple, but yet we all, and I say we because I think we're all partly guilty as well, we all don't get it right. And so the question is, what are the systems that we as governments, we as academics, we as funders, we as individuals can put in place to get these little things right? And I think the Asita's earlier JAMA article, I think starts to point this out, that we know certain medicines work great in clinical trials, but the reality is they never work nearly as well in the real world. And we know that there are many reasons for this, right? But at the end of the day, patients don't take their medicines as prescribed. Physician prescribing behavior is suboptimal. Funding is suboptimal. So there are lots of systemic challenges. And so what we are trying to do within COBRA and what payers are trying to do is figure out where are the leverage points so that we can deliver cost-effective healthcare to address what are very simple behaviors of diet, exercise, taking medications as prescribed, don't smoke, don't drink too much, a few other things. But these are systemic challenges that every transitioning and developed economy will face. I think COBRA has tried to systematize the process for a piece of that. And what we showed what Tazeen's team showed in COBRA in urban Pakistan was not only can you do it, but you can do it at a fairly low cost. And what we are doing here, and what we hope replicates on the effectiveness side, but what we already know on the cost side, is you can deliver the COBRA intervention in rural areas for a couple of dollars per hypertensive person. And so these things can easily scale, and we have systems in place that allow for doing so within the current health system, taking advantage of the community health workers, a model that generally can scale and that leverages on existing infrastructure. And we're hopeful that the results will show essentially what the urban COBRA showed, but if it does, it still means that there's systemic challenges that we need to overcome, largely in terms of funding, in terms of support, and in terms of systematizing the process, not just in a grant cycle, but long term. And then, of course, doing the things that allow this to be successful. And I think what these guys in the room can speak to much better than I can, my colleagues on my right and left, is how do you actually do that? So I think I'm just trying to set the stage, and we'll let these guys sort of.
First of all, it's a great pleasure here for joining this meeting, and thanks to Duke and US and Sri Lankan group, my colleague Asita. for facilitating this great forum, and respected chair and co-chair and my colleagues sitting on the podium. And it's a great privilege to be here today. Today, we are using slides, but I'm sorry, why is it not working? Where do I have to move? Okay. It's not a formal presentation, but we want to walk you through the pathway how we have integrated COBRA strategy in our health systems. COBRA was a new terminology, nobody knew about it. And NCD was not even a popular topic at that time, back in 2014-15, when COBRA has been trying to put a footprint in Bangladesh. So how we have done it, after 2 years, you have seen some of the expressions from Tazeen that we have done tremendous well. As the PI of the country, I'm blinded, not by eyes, but by the results. I cannot tell you the results. But I am every day living with these patients, with the doctors, with the system, with the health ministry colleagues, and I can tell what is being changed over there. So we try to do it in 2 districts, to bigger districts in Bangladesh. One is Attygalle, one in Munshiganj, and we did the trial, but we could not go beyond our health system. That is very important. COBRA cannot bring something new, which the government will not be able to adopt. It will require policy reform. That is impossible. So what we did, whatever the model we came up with as a global community, we tried to integrate it into the existing health systems. And who are the health stakeholders of the health system? It is starting from the Director General of Health under the Ministry of Health, who is the prime key stakeholders, and it goes down to the bottom at the community, including the community health workers in the community and the community-based doctors. And unfortunately, I was listening to Dr. Sania Nishtar that it was dangerously slow, and there are a lot of international community and actions have been taken. But I think most of us, we have done top-down approaches. We have not engaged our patients. We have not looked at the preferences. We have not looked at the convenience of the patients. So what we are asking the patients to do, have we asked them if it is convenient for them to do it, how they can make the recommendations fruitful. So what we really did, we did a very comprehensive qualitative research in 3 countries, and I'm going to talk a little bit about the reflection of Bangladesh study. We published this paper very recently. There we tried to see how patients get their hypertension diagnosed, and what patients do when they know they have a hypertension. It turned out to us very easily that patients don't actually go to doctors for diagnosing a hypertension. It is mostly done by default. Either they're being treated for other diseases, or somebody is very enthusiastic about the health and they want to know how their pressure is, because every community in the rural community will found a dispensary where there are local doctors. They measure the pressures and they get paid for that. So it's a good business. So we have found that these are not necessarily conscious people. Either they go there by default, by chance, or they have some other health problems. But whenever they are diagnosed as having hypertension, the government facilities, the qualified medical doctors may or may not be the first priority. It is their neighbor, the drug sellers in the community, or quack. They are their trusted friends. And because they've been living with them, they have been guided by them since their childhood, what to do, what not to do, and they go to them. And of course, you can imagine what may happen. Maybe while we get a lot of patients not getting treatment, you may get a lot of healthy individuals getting unnecessary treatment as well. So there are 2 pictures in the community. So we found that even when they go into the pathway of care, the patients have different preferences. They want to go, at the first place, they want to go to see a specialist. They don't want to trust a ground level medical officer, general practitioner sitting in the sub-district hospital who is trained and well equipped to treat patients with hypertension. And we have been seeing this before we implemented COBRA. We still see that after we implemented COBRA. So this is a kind of behavior. So it is so difficult to change a behavior. And it is an individual's responsibility. We may have policies, we may have excellent systems, but if an individual patient does not want to take the medicine, if the patient doesn't want to have healthy diet, if the patient does not want to walk, how can you make her walk? So it is a behavior change, and this behavior change needs to be integrated at an individual level. So what COBRA has designed is trying to reach these patients, and only to trying to reach these patients and engage them according to their preferences. All the strategies are coming in. These community health workers going door to door and measuring blood pressure, and when they are finding they're having uncontrolled blood pressure, referring them back to the hospital, where we have trained medical doctors who can treat patients very well. That has been implemented only because the patients would find it convenient and it may help patients. So what we have done, we simply needed to make some agents, how they can make change. So COBRA has behavioral change communication materials, and there are some general guidelines. And in Bangladesh, we actually added some few additional guidelines, because in Bangladesh, flip charts are very popular for any program, so they do it. So once we did it, we really needed to train the health workers at the grassroots level, who can go home and bring the trust. And even if we train the patients and how to do lifestyle modification and take drugs every day, if we don't make the drugs available to them, if we don't make the drugs or doctors available to them at their convenience, it will never work. So, yeah, right. Okay, so in 2 minutes. So what we did after the training, so we also enhanced the capacity of the NCT corners at the government hospitals, where doctors are trained with algorithm-based treatment, and drug supplies were ensured, and a non-functional NCT corner became functional in a few months' time. And there is some incentive mechanism that work for the government health workers, but the incentive mechanisms not necessarily work for the patients, because in this community we didn't find poor patients a lot. So we have to find out some other mechanisms, probably how we can also bring patients with uncontrolled blood pressure come to the health systems. So what we want to say by my concluding remark would be, all these things that we have achieved in COBRA so far, it is an excellent journey. That journey would not be possible if we did not have the support from the top level Director General Health Services. They are the champion. They did everything. We just trained them. We just monitored the performance. And you can see a picture where the Director General Health Services is sitting there, and our champion was Additional General. Yeah. So this is an example. Yeah. This is the excellent example where top-down and bottom-up approach can merge together. Thank you very much.
So much to say.
We are nearly at 12 o'clock.
Then I'll finish by the time. Please have your seat.
When I stand up again, we'll... Okay.
Okay. Throw me down. Next slide. I can do that. So there were a few pointers that were given to make this presentation. What have we learned about the integration of NCD care services and its financing from COBRA-BPS in rural Pakistan? With this, I would like to say we have to begin with what existing healthcare system we have. This is just a few things, a few I think slides just to share that we are doing this in the province of Sindh and in district of Thatta, in 2 talukas, and this is how one district looks like, and this is the profile of one union council. So the Pakistan existing healthcare systems is based on the primary care, secondary care, and tertiary care, which is nothing new. This slide applies equally well to Sri Lanka, Bangladesh, I hope so, and India, because our system and the system of India is very close to each other. So the primary healthcare is that we have the first level healthcare facilities, and then the outreach, community-based community health program. And then at the secondary level, we have got the taluka headquarters and the district headquarters. One is the facility, referral facility, and the other one is to care provide to all those who were referred from the primary care. And then the tertiary care, and most of these tertiary care hospitals are affiliated with the teaching hospitals and are called the teaching hospitals also. At this point, if I take you through that at the basic level, this is a great opportunity to tap on, to capitalize on, because the entire system is there, but the NCD is missing. There is a BHU doctor, there are lady health workers, they are reaching out into the community. So there are very important and sound points, and with, of course, there will be additional cost, but we can capitalize on the human resources and all the infrastructure, and they can train them to implement the non-communicable diseases as well. Having said this, another point that we have been hearing about the maternal child health, we can learn a lot from there. We are also seeing that maternal and child health, what it has shown. Still we say that many of the targets are stagnant, and many of the countries have not shown any progress. Then I think we can again learn lessons from there to begin with our journey in the NCD, that we should not repeat the same mistake of the maternal and child health. The ground is ripened. I think the national and the donor agencies, they all have learned, and we are all geared with the COBRA strategy to implement, at least I think in these 3 countries and 2 other developing countries, the non-communicable diseases strategies to implement, begin with the control of high blood pressure, diabetes, and then the list is not finished, because I'm fully prepared that we can implement the screening for the 2 cancers at least, primarily for women. Begin with women first. Finally, this is all the red pointers are showing that where we want to make the changes in the reconfiguration in the existing health systems. There is no NCD line, no NCD budget, no NCD focal person. So therefore, there is no NCD program in the existing healthcare system. All the red pointers are that there's no HMIS, there's no doctors training. So all these red pointers are to be reconfigured. LHW training, BHU doctors training, how to screen, how to measure, how to manage, how to use the algorithm, and the most important thing is the district health systems, how to reconfigure the existing district health systems, from where the checklist will be beginning, where it will go, how it will come to the DHO's office, and then to transfer to Islamabad, our headquarters. So reconfiguration, important pointers are to integrate the COBRA strategies, the referral loop, number 1, training, finished, and then the DHIS. So these are the 2 pointers, and then I would like to see some of the pictures. Yeah, so we have also done the trainings, government clinics, training of the private doctors, and this is how the LHWs, they are making their routine home visits. They are visiting the households. They are seeing the maternal and child health. They can also see an adult person with hypertension.
I guess better look from here.
This is so beautiful.
I'm not going to collude with you. I think it's time to finish. Okay?
Okay.
Okay. Thank you very much. Now, Anu Kasturirathna is going to speak about the Sri Lankan experience. She's co-PI of the Sri Lanka COBRA.
Thank you, Chairpersons. I'm making this presentation on behalf of the Principal Investigator in Sri Lanka, Professor Asita De Silva. So what we have learned about integration of NCD services and its financing from COBRA-BPS in rural Sri Lanka. To go straight into existing health infrastructure in Sri Lanka, here actually this diagram is about how the patients are diagnosed, treated and followed up in our setting. As you all are aware, there are so many venues for people to be diagnosed, starting from the hospital outpatient departments, hospital clinics, hospital in-ward settings, field clinics, sometimes especially opportunistically being diagnosed in other settings like MCH clinics, and the private clinics in the private sector. So after diagnosis, most of the patients are treated long-term in the hospital setting. The majority of the patients in our study, as well as the community, are being treated in hospital clinic settings in Sri Lanka, which are part of the free health services. A component of the patients are being seen in the private sector. Follow-up is again divided between the hospital clinics and the private clinics long term. These are some pictures from our training and especially how the PHMs, who were the main stakeholders in delivering these services, were trained. They were a very enthusiastic group of learners in this study, and this training was able to give them a lot of skills, especially skills in communicating, imparting knowledge, and even use of digital blood pressure measuring devices to monitor and refer patients to doctors in the field. This is a triage counter. I think even in all 3 countries this has been established. In our setting, this was not a really new thing, probably, but in some settings, especially the most smallest setting like the primary medical care units, there was no space for this, so there was no avenue for this. So we have been able to create that and more or less to get them functioning. And health education material being used by the patients and how the doctors are seeing the patients. So talking about the barriers of integrating COBRA-BPS strategies in Sri Lanka, we have looked at a number of aspects. One of the key things about providing home health education by the community health workers in our setting, these were PHMs. Some of the challenges we encountered were, first of all, the incompleteness and inaccuracy of checklists filled by the CHWs. So we developed a number of strategies to overcome that. And sometimes patients seek medical support from hospitals located outside our region. Part and parcel of this study was to refer the patients within the region. But then, because of the freedom and the flexibility the patients have, they may seek care all over, sometimes even outside the province. And inadequate time spent by the CHWs. This is a problem of the workload and a lot of competing demands. Yes. Yeah.
So anything you want to emphasize?
Of course, the incapability or the challenges faced by the community health workers in handling a workload. This is a big challenge in this. And then the non-adherence to referral system by the patients mainly. Then when we think about the doctors' involvement, we try to involve the doctors in the private sector as well as in the government sector, because in Sri Lanka, most of the doctors who work in the private sector are also government doctors. So in training, especially we wanted to get them trained on a protocol according to the study, but getting their participation for training continuously, that was a challenge. And then the workload issue again, reluctance in filling the checklist, and the poor cooperation sometimes when there are full-time GPs in the community, they're completely in the private sector. Their cooperation is a difficult thing to gain because they are not under anybody. The triage counter, we had a problem in shortage of manpower in managing the triage counters and running them throughout the course of the study. And there are concerns about the safety of the equipment because these hospitals are very open places, small hospitals, open places, and if you leave the equipment for a long time, actually the center management is not happy to do that. So these problems are there, and also the decision making by the staff in allocating patients to appointments, that's a challenge, and so we try to sort out these things by different strategies that we have developed in the job. Yeah, yes, yes. The travel voucher system, which is helping patients with poor socioeconomic status and uncontrolled hypertension, is not very successful in our system because of the problems in reporting income as well as the problems on the healthcare workers. They don't want to miss out anybody because this is a welfare-ish activity. So we had to have different mechanisms to get around that. So to summarize, I think there are a lot of facilitators in our system too. The well-structured health system with good coverage and the free health care which is available for the entire population, the role of the CHW in the present context, their acceptance, they are being able to pay home visits, all these are positives, and they have a huge capacity for improvement as well. They have a have had a comprehensive training in healthcare, MCH-based and field-based, including communication skills, so we can develop a lot on those and build on those. And then the emphasis on NCD in the health system in Sri Lanka, because we have a Deputy Director General as well, and increased funding and development of infrastructure. Just to and of course, I don't want to miss out the new pricing policy on drugs, which is actually very favorable to patients on long-term care. Thank you very much.
Thank you so much.
Okay, I'm going to hand over to my co-chair. I've had to do all the naughty work.
I've done it very well, I'm sure you'll all appreciate it. Thank you very much indeed to each of the speakers from our countries. Are we going to have some time for questions from the floor? I think that's what we would like to move over to now. So we're really keen to hear the questions that you have for our experts here who have been working on the ground in these countries. So who would like to start off?
Thank you. So in terms of integrating NCDs into primary health care, the three countries are at different levels of starting. From my personal knowledge of what happens in Pakistan and Bangladesh and Sri Lanka is way ahead because they have their lifestyle centers, they have started the total risk approach, and they have also at some stage had lots of discussions about engaging the midwives and have had discussions with the Family Health Bureau, et cetera, et cetera. So my question is, it's more than a question, it's a statement. I hope that this project, of course, will bring in valuable lessons and that will give input to the Sri Lankan situation, but that it will not be a step backwards. This is because they are a way ahead in terms of, for example, addressing hypertension. My actual question is to Bangladesh. Some time ago from WHO, when we started working in primary care in Bangladesh with community health workers, the doctors obstructed the whole exercise, saying that they will detect hypertension and flood the primary care with new cases, and doctors did not want community health workers even to consider prescribing half a tablet, quarter tablets of hydrochlorothiazide. Has that situation changed?
Thank you for your great question. That situation hasn't changed. It is the policy of the government, and it is, of course, the health system's policy that only the qualified doctors can prescribe medication anywhere in the country. And any other non-medical provider support, they are allowed to supply and follow through prescriptions. So what you have portrayed is a long time back, and there is a lot of divisions and a lot of difficulty in working together. But now the community clinics have been expanded very extensively, and NCD training has happened with the community healthcare providers. And more importantly, at the community clinic level, there are glucometer given and there are blood pressure machine given, and these workers are capable of assessing diabetes and hypertension right there. And now the government, we have a deputy program manager, Dr. Alim, with me, and he can supplement if I miss something. But the government is really trying to make a lot of progress with the current NCD strategic action plan. And there are being assessment and new protocol developed, how the simple treatment guideline can be developed and that can be implemented throughout the country to avoid this kind of situations and who can prescribe, who cannot prescribe. So the bottom line is that situation has been very positive at the moment. And the government health workforce, such as if NCD is implemented, the kind of operations that we have engaged the community health worker at the grassroots level, that will be one of the models. So it is going to be scalable in the end.
That's wonderful. Thank you very much. I think we just have time for 2 more questions.
No, just a comment on that. And from Sri Lanka, I think the Ministry of Health, Deputy Director General Public Health is here, and there are a lot of clinicians here. I don't think we are planning to have community health workers prescribe medicines. I think what you're going to do is follow up, train them to measure blood pressure, refer them to hospitals, follow up on the prescriptions and so on. Am I correct, Dr. Vohra?
We have not gone to that level. I think the clinicians, the doctors should start prescribing here. The main aim is to detect hypertension at the community level.
So let me just add here that when we were designing COBRA, we had extensive discussions. For our first model that we originally wanted to do was we wanted the community health workers to be doing at least prescribing one or two, just your hydrochlorothiazide maybe and an ACE inhibitor or CCB. That we thought was going to be very effective, and we went back and we argued extensively with the three countries. Can it be possible that a physician co-signs, even let them, so we had extensive pushback. It was not going to be possible in any of the three countries, even for like a nurse clinician model. It was just not going to work with even a single drug, even a supervisory role that they later somebody, so it was just going to be a no-go. So not.
Thank you. Very important question, and I really just want to add one comment from the perspective of Pakistan, that as far as the background of the lady health workers in Pakistan is concerned, it is varied. And so there are women who are not educated, just a little bit of education, and then they are up to class 10, and then some of these they have attended a college of 2 years also. So with this varying background, I think this is a question that really needs a big discussion at the country level in Pakistan, if we think any prescription to be made by the lady health workers.
I'm from Bangladesh. I am the Secretary General of Association of Physicians of Bangladesh, our premier platform of Bangladesh. Actually, we have designed a simple model for the treatment of primary health care, hypertension and diabetes, with the help of our specialist physicians and with our government and also ICDRB also. But like this hypertension, one group is 140, 90, and another is 160, 100. And a simple one drug or two drug like this. And actually, this model we will start very soon in our country, and our government will help. And my question actually is, suppose we have taken amlodipine or CCB or ERB, our cheap drug, and the very simple drug, government will provide. And my question is actually in other countries, I don't know this medicine will be same or not. For this reason, actually, I have asked this question. Suppose in diabetes, we will start with metformin and then other sulfonylurea like this. Thank you.
So, so I think in our scale up that we are proposing right now, I think we are also going with, we are leaving it to the individual countries, and generally we are going to be working with the diabetes associations on the individual countries, and generally so long as the country level guidelines are in line with the evidence and the international WHO guidelines, we will go along with them. So what you're suggesting is the first line will be metformin and the second line is sulfonylurea. That is a cost-effective approach generally, so this is the kind of approach that we are also proposing. It's consistent in all three countries. It's consistent.
Thank you. Thank you.
I'm really sorry. I think we've run out of time now. Just plenty of opportunity for people.
Just one comment. I would like to just very quickly ask you, the Sri Lankan participant in the study, whether it will dilute the other programs carried out by the community health worker at grassroots level, and we'd go back on our mother and child indices because of this, or whether we are planning and have recommended to the health ministry that we should take more workers at grassroots level.
That is definitely an important concern. Thank you for that question. Of course, I think the Ministry of Health is also thinking on these lines. At the moment, our PHMs are dedicated to maternal and child health work and other related work like nutrition. So there's this problem of overloading. Definitely, unless the CARDA is improved and the population under care is managed or located a lesser number of people under care, this is going to be a problem. So this is what we should be discussing, I think, with the office one of the important concerns on this upscale.
Thank you very much indeed for that important comment, and I think it demonstrates how we need to make every contact with healthcare workers at whatever level count for the maximum benefit across all of these important issues. So I'd like to thank everybody who's participated in panel, both from the floor and our excellent speakers, in showcasing this very, very impressive project where the COBRA project has been so successful in reaching out into communities across these three countries and trying to tackle the problem of hypertension at so many different levels. I don't think we've got time for more details on that. So I think we'd like to ask you to again thank our presenters from each of the countries for giving you a wonderful insight into their work.
Is he working?
Next slide. Yes.
Thank you, ladies and gentlemen. That brings us to the final panel discussion, and not to take off any gloss of what's been going on, but I think this is the final one is perhaps the more important one, to focus on what we have done and what we can do and achieve in the near to long, medium-term future. So for this panel discussion from Sri Lanka, may I invite Dr. Susie Pereira, Deputy Director General Public Health Services from the Ministry of Health, Dr. Deepika Attygalle, Senior Health Strategist from the World Bank, Dr. Mubarak, President of the Heart Association, to join us here. Tassin will introduce the co-chairs as well as the other panelists for this. Tassin? Tassin? I brought the Sri Lankans on board. Yeah, come on up.
Okay, can I first get the two co-chairs? They're right here, Professor Richard Smith and Professor Shah Ibrahim. And Richard will self-introduce himself before we start. And I'd then like to call our panelist from Pakistan, Professor Khawar Kazmi, who's a preventive cardiologist, head of preventive cardiology, has been at the Aga Khan for 20 plus years as the head of cardiology there, and has now moved to the National Institute, the premier cardiology institute in Pakistan, the National Institute for Cardiovascular Diseases, and is the head of preventive cardiology there. And we also have Professor Mustafa Zaman from the Association of Physicians of Bangladesh, the leading association in Bangladesh, and the Dr. Abdul Alim, the Director General of the Health Services at Dhaka, Bangladesh. They've been very instrumental in assisting the COBRA study, and we are very grateful to all of our panelists who have really been assisting us, and we really look forward to their views. So over to you, Shah and Richard. And
Richard, just one quick addition here. Just to complete the panel,
yes,
we have invited a patient who participated in the study from Putlam, Mr. Chandadas, who's seated right at the end, just to get his perspectives, if you want to, about the study and how he feels about what has been done.
Good. Well, welcome everybody to this final session. So I'm Richard Smith. I'm primarily known for what I'm not. I used to be the editor of the BMJ years ago, and I was on the editorial board of the Ceylon Medical Journal. So it's really a lot of fun to be here. I've been here twice before. I'm going to be co-chairing this with Shah. We are nice and nasty. You can know who's nasty already, so I am nice. We've got a very big problem here, not only in terms of hypertension and NCD rising across the globe. We've also got a big problem. We've got a hell of a panel here and not a lot of time. So I think we're going to have to be brutal. I'm going to set my clock. You were going to be allowed 5 minutes, but I've taken a decision to reduce it to 4 minutes. And if you can do anything less, that would be even better.
We also have Professor Shanti Mandis on this panel.
We've got a chair for you here, Shanti. Come on up.
Can we
Come
get
on
another
up.
chair, please? No. Is that?
Oh, look,
Yeah.
we've got an empty
No,
chair.
we get her on the panel. Okay, thank you.
And you're joining as well, Tazeen, aren't you? No, you're not. Okay, right. So we've got a big problem, and as Shanti made clear, there are lots of other problems in the world. So if you are the Prime Minister of a country, you've got a hell of a lot to deal with, and how do we help them deal with hypertension? And what is very clear is this can't just be done by one player. So the main point of this panel is to hear from other players in the system what it is that they can contribute. So we're going to kick off with Dr. Deepika Attygalle, who heads the World Bank here in Sri Lanka, and I'm going to set my clock for 4 minutes. Do you want to come up here, or? Okay.
Very good day for all of you. Thank you very much for inviting us, Professor Asita and the organizing committee. Just very briefly, the World Bank contribution for next 5 years in Sri Lanka in order to strengthen the primary healthcare system with a high focus on non-communicable diseases. Can you do that? Oh. Will you do that? Right. So, to support the country's main objectives in long term as well as in short term, to preserve our progress and prepare our future. That is always to maintain the country's achievement in MCH and the preventive sector services, and also in order to achieve the universal health coverage through primary healthcare system strengthening. So you see over here, to provide citizen-centric integrated healthcare that is affordable, sustainable, and ensure continuum of care for every patient. So where the high coverage, essential service package for each and every citizen with the affordable cost, that is financial protection. So to start it off, for the next 5 years, it has been decided to provide services as well as to invest in various programs in order to increase the utilization and quality of primary healthcare services with an emphasis on the detection and management of non-communicable diseases. This doesn't mean that only non-communicable diseases will be supported by this project or the program. Of course, there are many emerging challenges in the health sector: aging, the geriatric care, the mental health, the palliative care. All these things will be taken into consideration, but it is the Ministry of Health who needs to decide the project plan and the activity plans that should be invested into this primary healthcare system strengthening. So I'm not going to share the other slides, but to highlight the importance of investing in primary healthcare facilities, this slide itself shows the investment pattern in Sri Lanka. It is more towards the tertiary care hospital as well as the secondary care hospitals. So this highlights the importance of investing in primary care facilities or the primary healthcare system strengthening, where the World Bank has agreed with the government, particularly with the Ministry of Health, to invest in the next country engagement for the strengthening of primary healthcare. So I'm not going to highlight those evidences. There's a plethora of evidence to support that non-communicable diseases are very important. To strengthen the primary healthcare system is very important. So based on which the government has agreed with the World Bank to invest in those areas. So going back to the next, the second slide. Next one. No, second. Next one. So this slide is recently the study that was done by the World Bank with the support of the local consultants. This shows the even the observed, the screen population and then the gap between the observed hypertension, the diagnosed hypertension, and the treatment, and also the control of hypertension. So those gaps need to be taken into consideration when we plan our next project. So finally, those are the key areas. Next one. So these funds could be used to develop strategies or to make plans to improve the integration of comprehensive primary healthcare services with a high focus on non-communicable diseases, and to introduce or to strengthen the information management system as well as the supply chain management, and also to increase or to empower the community engagement or the citizen engagement. These are the key thematic areas that the next country project will be invested in to improve those areas of the next project. So I'm sure that with all of your help, with the professional colleges, the academia, and the Ministry of Health, we'll be able to get the expected return for this investment in the years to come. Thank you so much.
Thank you very much. I think we've known for years, if you really want to make a difference in health, you invest in primary health care. Yet the graph you showed, in every single country, I think it tends to go in the opposite direction. What I suggest is, does anybody else have slides? Hooray! You've got slides? Right. Right. Well, why don't we, what I suggest is so if you could come and arrange for your slides to go up. Let's move along the panel. And if you can manage to do it in less than 4 minutes, that would be fantastic. And so if you line up your slides. So you come next. Let's introduce yourself and then say what it is you have to say.
3 or 4? 3 or 4 slides.
Oh, you're using the slides together, are you? I was thinking you could line up your slides while others spoke, or if you've got them already. They're all ready. Okay, fire away. Oh, no.
Respected Chairperson, dignitaries, and the learned audience. I'm from Bangladesh, already have mentioned that I'm the professional clinician, I'm the cardiologist and Secretary General of Association of Physicians of Bangladesh, our professional body. Actually, our role in this, excuse me. Hello? Hello? Help me, please. Okay. Management with a standard treatment protocol in primary health care in the light of universal health coverage. Actually, we're doing simplified our protocol for our primary health care level and in the uniform fashion in all over the countries. And we can, for that reason, we are doing last few years, and we have simplified the model of treatment for the treatment of primary health care level. Why simplify treatment options? Improve quality of clinical care, reduce clinical variability, enable task sharing with healthcare team, optimization of drug supply for the NCD care, enable reduction in cost of medication, and enable evaluation of impact. This is our national guideline established in 2013, but besides this, the worldwide lot of guideline, but we have mentioned this protocol. We have selected, suppose only two drug for the treatment of, because of low income countries and low resource our government, and for that we have selected calcium channel and ARB. But first we select the calcium channel blocker, and then ARB, and then therapeutics in a like this. Suppose blood pressure is from 140 to 159 systolic and diastolic 90 to 99. We'll start from amlodipine 2.5 to 5 or as per international system. And then we can add the allostatin. And like this, we can system the referral system when we can refer the patient to the specialist. Again, I mentioned that this treatment will be given by the medical officer who is sitting in the primary level, but not by the specialist and not by the city-based. our city has our professor only by our primary health care, but the medical officer will give the treatment, but they can refill the medicine from the community clinic where there's no doctor, only for our paramedics. And next, if blood pressure is more than 160 and diastolic is more than 100 millimercury, we can start the combination treatment, amlodipine plus losartan potassium once daily. And then if not target met, amlodipine 5, losartan 100. If treatment not target met, amlodipine 10, losartan 100 once daily. And we can refer the patient. If patient is supposed an gynecologist, they can refer to the endocrinologist, cardiologist, medical specialist, nephrologist, as per the problem of the patient. This is very simplified, actually, and protocol, and which will help our rural people to receive low-cost treatment. If we can see the picture, our president of Bangladesh, Abdul Hamid, he also actually admit this type of protocol, and we have present in Bangladesh also, and our health minister is there, and I am the Secretary General of our countries. Thank you. Thank you for.
Well done. Can I ask, is your protocol on one page? It is? Yes. That's good, that's good. We have ones that are 170 pages long in Britain.
Honorable Chair, Co-Chair, dignitaries of different organizations, welcome to all to this session. My session is role of key stakeholders in hypertension and diabetes in care in rural Bangladesh. You know, Bangladesh is near about 67% hospital death is due to NCDs, and most of them are due to hypertension, diabetes, COPD, cancer, these major NCDs. For this reason, the government of Bangladesh make a sector program. This is called SPNSP, Health Population Nutrition Sector Program. This operational plan is 5 years plan, and its target is to reduce mortality and morbidity from NCDs in Bangladesh through controlling of risk factors, improving health service delivery options. And priority activities of Director General of Health Services for Non-Communicable Diseases is screening of major NCDs, referral, management of major NCDs, health promotion and risk reduction, monitoring and evaluation, observation of different NCD days, multi-sectoral coordination, NCD surveillance, and multi-purpose health volunteer. This is a new dimension in our health system. You know, Bangladesh has a community clinic for 6,000 rural population. This 6,000 population under the guidance of this multi-purpose health volunteer, this is recruited from this year. There is about 5 number of multi-purpose volunteer for this 6,000 population, and this multi-purpose volunteer go to the house to house for searching of NCD, that means diabetes and hypertension first. And after screening there, they go to the community clinic, and community clinic is, they are measuring the blood pressure, and by glucometer and strip, they are measuring the blood sugar. And if they are positive for pressure and diabetes, they are referred to the USC, that means sub-district level hospital. There we have the NCD corner, and there is a doctor who again measure the diabetes and hypertension of this patient and confirm and diagnose the patient as a hypertensive or diabetic. If the positive patient, they give a health card and give them the treatment and management, and give the, according to our national protocol, we give them the treatment for diabetes and hypertension for 1 month, and refill the drugs into our community clinic. This is the system we are adopting in Bangladesh. And this is the, yes, okay. This you seen earlier. And this is integration of COBRA and BPS in public sector. The priority activities of Director General of Health and the multi-component intervention of COBRA, that is screening of major NCDs, referral, management of major NCDs, and health promotion and risk reduction. These are aligned to the COBRA studies. This is training for community health workers for screening hypertension, referral mechanism, treatment algorithm, and healthy lifestyle promotion. This integration, the government program and the COBRA program is integrated. That's why in our rural system, it is integrated, and scaling up is timely and essential. And objective of DGHS, the sustainable public policies, evidence-based public policies, and from COBRA, the strength capacity of the health system, and strengthening of capacity of health system. And thank you.
Well done. Thank you very much. Well, that's impressive that you've thought about how to incorporate COBRA into your system. Right, now Dr. Khawar Kazmi from the Pakistan Cardiac Society and National Institute of Cardiovascular Diseases.
Okay, first, thank you. I think first I'm pleased to announce that I don't have slides, so. Okay, so I think it's clear that 3 countries are for their primary care level at a different stages. And in Pakistan, I think as it was mentioned by Imtiaz, we don't have NCD as a priority for the government. So our first task would be to convince them that this is high time, that this need to be included in their priorities. The issue is obviously that the budget health allocation is very small anyway, I mean lowest in South Asia and Pakistan. And then there are issues of misdirected priorities. Like I've recently moved to a public sector institution, National Institute of Cardiovascular Diseases. In last 2 years, they increased their annual budget from about, I think, $1 million to about $800 million. So in 2 years, it was increased to that. But all of that money has been used to put in 5,000 stents for acute MI in 1 year. So, so I think that's my task to go there to convince them that, I mean, some of this money has to be used for other purposes also. So there are this issue of misdirected priorities, and there are a lot of reasons for that, because politically, putting a stent in an acute MI is a lot more attractive slogan than giving drugs to hypertensive patients. Then I think there is another issue which maybe also in the other countries also, that the physicians who are working in the government hospitals, they also have private clinics. So if you go to a district hospital or Talaka hospital doesn't have a doctor in the day. So all the patients are just seen by someone else if there is any health physician. But in the evening, their clinics are full. So all those physicians are actually being treated in their clinics. So this is this economic parity which has to be addressed. And the same institution where I went in, I mean, 2 years, I mean, they have done primary PCIs, but there are certain good things they have also done. They changed the model. They said no practice outside. So you only can practice inside the hospital. So you have your private clinics inside the hospital. So that that has changed is that now that hospital is 24/7 open. There are services in the evening also, even for general public, I mean, apart from private clinics. So, I mean, that's something which we may have to think of the model, that if we do not change it, the money is, I suppose, the strongest driver for anyone, an individual. So if we do not change that, I think it'll be even, we bring in more hypertensives, will benefiting those physicians in their private clinics rather than the patients in their. So I think there are challenges. We will have to all address those challenges. And I think even a scale-up study of COBRA would probably start at different timings and different levels in 3 countries because of their local situations. But I think it is, it's time that we do that, and we're going to do that together. Thank you.
Good. Well, I've got time to ask you a question. So are cardiologists part of the solution or part of the problem?
I think they are part of a problem. They should be part of the solution.
Very good answer. Right, now we're going to move on to Dr. Champika Wickrama Singh. Forgive me for mispronouncing your name. All right, right. Okay. Come on up, sorry.
I just got 2 slides. First one is the policy. So Sri Lanka, I think we have understood our problem. We have analyzed what our problem is. Because as I think Professor Shanti Mendis, Madam, you quite correctly said, if we only look at hypertension and diabetes and have a program for that, it's like all our vertical programs that we have in the country. We have been doing quite well in Sri Lanka. We are left with certain challenges, and now we're looking at how do we integrate these vertical programs into a well-grounded primary care system. That is the policy that we have come up with, and this was recently approved by the Cabinet of Ministers in April this year. And this is a reform for universal health coverage. It is based on the premise that we have a good primary care system, but we are not doing so well for non-communicable diseases, the conditions of elderly care, and for mental health and cancer, basically the areas covered coming under non-communicable diseases, and we need integration. At the same time, we heard from many of my colleagues that, okay, we have a good MCH system, and also would the gains be sort of undermined, or would we sort of be challenged, because now we are putting in this emphasis on NCD. So this is what this policy is addressing, and this is not the time to be spelling out the details of this policy, but I just have one slide more. Can you just put the next slide? So the ingredients of change, I have kind of coined it as ingredients of change. So we are looking at changing the supply, also changing the demand, that is the people, because we, as Asita mentioned, you quite correctly mentioned, we have put in the drugs into the system, the laboratory services are also changing, all these are changing, but still we have people who are undetected, and even if they are detected, they are not complying with treatment, right? And at the other end, we have a country with very high literacy rates, and we have an MCH service which has been founded on this literacy, and why cannot we do the same for these conditions of non-communicable diseases, right? So this is why we are looking at a behavior change for lifestyle and for health-seeking behaviors. And therefore, we are moving towards health literacy and empowerment. So this policy is looking at these dimensions. Then from the supply and service side, we are looking at more primary care integration, life course approach, essential service package, which is already developed, and it is in a draft which is almost in the final stage. And of course, the skill mix. So the human resource is a critical challenge we have. And if this box can be addressed, it is going towards the effectiveness and quality of care. I'm really being very, very, I'm simplified it a lot, right? Because I know the constraint in time. And of course, the conducive environment, which is the policy on risk reduction, which we are integrating into the system. And of course, monitor. The strengths of our public health system, the MCH, has been on monitoring and the fact that we have a free health system, so we want to continue that, but monitor. So the cluster units that we are thinking of in the reorganized model of primary care is all about putting accountability. One doctor for 5,000 population, complemented with this other field staff. So we are talking of a system which is being accountable not only for the primary, the MCH services and the communicable diseases, but also for NCDs, right? So it is in that backdrop that the COBRA study will contribute with the protocols that you develop on the management, will come into supporting the supply of services plus changing the people's demand, right? So thank you.
Thank you. Just wait there a minute. So Shanti had a very blunt question about how could COBRA make things worse rather than better. But you're confident they can make things better?
I think if we spell it as a protocol and improve, train the people, because we are looking at a major change in the provider behavior, right? So there are a lot of capacity building inputs coming in there. But if you just put it as what Professor Shanti Mendis said, as another vertical program going in for NCDs, then we are making a damage to the system, right? So we want very careful integration. NCDs integrated into the rest of the system. That is the model that we have presenting in the policy, and it's going to be, discussed at provincial level, and it's now, and the World Bank support is really coming in to implement that. Plus we have the ADB support also. Thank you.
Good. Well, thank you very much. So now, who else do we have to speak? Please come on.
Good afternoon. I am one of those who insert stents. And there's one my colleague, Gota, is also there to support me in this audience. Thank you, Asita, for inviting me on behalf of Sri Lanka Heart Association to this forum. We normally don't get very much patients in the primary setting to look at hypertensive, but we do have patients. But when the patients, most of the patients come to us, they have ended up in the end-organ damage. And we see patients with hypertension, with diastolic dysfunction, left ventricular hypertrophy, heart failure, atrial fibrillation, and angina, acute coronary syndrome, and acute myocardial infarctions. When we see these patients, they are in the hands of cardiologists at the end. So morning when I had a chat with our senior nephrologist, he said hypertension is a disease for the nephrologist. I said it's disease of the cardiologist, but finally I agreed it's a disease, a vascular disease. It belongs to both end organs, finally end up that. Important point, when you detect hypertension, these COBRA programs, and we have to emphasize the patients that it's a lifelong treatment. Most of the time it is detected and treated, and after that they give away the treatment, and again they get another episode of hypertension, and with that they sometimes come with heart failure, acute pulmonary edema, flash pulmonary edemas we see. So those should be emphasized in every point when you detect hypertension. And I have to make one point, make a special comment or special recommendation to some of the patients whom you detect and treat with whatever treatment in your countries, whether it is AC inhibitors, ARBs, amlodipines, and it doesn't matter. You have to control the hypertension. We cannot split hairs between the groups. Control of hypertension is the important. Hypertension is the major risk factor for cardiovascular disease, apart from, in addition to others. So when a patient is diagnosed hypertension at a young hypertensive, hypertension which is resistant hypertension, not responding to these treatments, or patients hypertension with some endocrine damage, or the patients which has a urgent emergency hypertension, that is a very high blood pressure and detection. These patients should not be dealt in the primary care, should be referred to specialist centers. Those should be emphasized because they are the immediate danger of to their death or cardiac mortality and renal failure. So I should finish my here, and I should emphasize that we learned our basics medicine from Professor Shanti Mendis 25 years ago, and there are 3 students here, myself, Gota and Naza, all were in the same batch, 1 nephrologist, 2 cardiologists, and we were some inverted commas good students at that time. So now we are here. Thank you very much.
No, wait a minute. Thank you very much. Actually, I've got a friend, Rod Jackson, who's Professor of Epidemiology in Auckland. He says hypertension's not a disease at all. It's just a risk factor. And he says the same. So if I understood correctly from what Asita was saying, the majority of people in this country with hypertension are being treated with monotherapy, and yet we recognise that the vast majority need more than one drug.
Yes.
How has that happened, and what can be done about it?
Because monotherapy, that's because of the availability of the drugs. When you go to the peripheral centers, sometimes that may be the only drug available sometimes. It may be nifedipine, it may be losartan, it may be captopril, or it may be enalapril. These are the common drugs, and hydrochlorothiazide as well. So we have to make aware that starting multiple drugs, 2 drugs, 3 drugs at the beginning itself will be more productive and more efficiently control blood pressure. And as we all know, we know that most of the hypertensives are not under control, even in the Western world. So we have to emphasize the fact, start 2 drugs. That is at least 2 drugs at the beginning itself, not to wait for the hypertensions to continue and then add another drug, add-on therapy. Thanks.
Still has Shanti, do you want to say another word, or you've had your crack already, or do you want to say more?
If you want me to, but I can
Well, I think if we could save it for the questions.
No problem. I can also shut up.
Okay. So, last person. Oh, you're right. Yes. No, this is good. Yeah, because I think one thing we've constantly lacked in NCD world is the voice of patients. So now we have the voice of a patient, but he's going to translate.
I would be translating for Mr. Chandradasa because he will be speaking in Sinhala. Mr. Chandradasa is a 52-year-old hypertensive from our community in Putlam. He lives in Mahaweva Medical Officer of Health area and runs a business in the nearby town. So he has been recruited into the COBRA-BPS study. Basically, he will speak about how he got into the study and his experiences on that. Mr. Chandradasa, study එකට කොහොමද ආවේ? මොනවද ඒකේ ලැබුණේ කියලා.
මට මීට අවුරුදු 5කට විතර කලින් තමයි මගේ නම වසන්ත චන්ද්‍රදාස. මට මීට අවුරුදු 5කට විතර කලින් තමයි මම මේ අධිරුධිර පීඩනයක කියලා තියෙනවා කියලා දැනගත්තේ.
Just a suggestion, it might be a good idea if he says just a little and then you translate. It'll be easier for everybody.
මම මීට වසර 5කට විතර කලින් තමයි මට අධිරුධිර පීඩනය තියෙනවා කියලා දැනගත්තේ. ඒ දැනගත්තත් මම වැඩි ඒ බෙහෙත් ගන්න පයින්නුවේ නැහැ කියන දේ අහගෙන හිටියා. බෙහෙත් ඉංග්‍රීසිලා ගත්තා. පස්සේ ඒක වර්ෂ කිහිපයක් නැවතුණා. ඒත් පස්සේ පෞල් සෞඛ්‍ය සේවිකාව සහ මේ වැඩසටහන පටන් ගත්තට පස්සේ අපේ නිවසට ඇවිල්ලා අපේ රුධිර පීඩනය පරීක්ෂා කරලා කිව්වා යාට මේ වෙනකොට රුධිර පීඩනය වැඩි. ඒකින්ද ඔයා මොනවද බෙහෙත් ගන්නෙ කියලා. මම කිව්වා මැඩම් බෞද්ධ දවසට නවත්තලා හිටියේ කියලා. ඊට පස්සේ යා මේකේ ලෙඩේ ආධිනව ගැන මට මතක් කරලා දුන්නා. ඊට පස්සේ ඔයාට මේක මෙහෙමයි වෙන්නේ. මේක බෙහෙත් නොගෙන හිටියොත් ඔයාට අවුරුදු එතකොට මට අවුරුදු 52 වගේ වයසේ හිටියේ මේක පටන් ගන්නකොට. ඔයා ගෙදර ගෘහමූලිකයා. ඔයා ගෘහමූලිකයා වශයෙන් ඉඳලා මේක ලෙඩ හැදිලා හදිස්සිය ඔයාටම කරදරයක් වුණොත් ප්‍රශ්නයකට මුහුණ පාන්න වෙනවා ගෙදර කට්ටියටම. ඒකින්ද මේ බෙහෙත් ටික හරියටම වෛද්‍යවරයෙකුට යොමු වෙලා ගන්න කියලා මට සඳහන් කරා.
Mr. Chandradasa had been having hypertension for the last 5 years. He has been taking treatment from the private sector majorly, and he had been on and off drugs at times. So when the study started, he was approached by the study team initially, and his blood pressure was checked, and he was recruited into the study. So at that time, after that, the public health midwives have come to his house and advised him about the seriousness of the condition and the problems of not being on treatment. And then he had been advised on compliance, and he had been referred. Through this, he had actually he had not considered the condition very seriously initially. So once he was recruited, he had been advised on the gravity of that and put on referred for treatment.
ඒ කාලයක් යනකොට තව මාසෙකට සැරයක් විතර වගේ මේ සෞඛ්‍යවාදී නිලධාරීන් නිවසට පැමිණිලා කතා කරන් ඉදියා ගොඩක් අපේ ආහාර රටාව ගැන ඇහුවා. අපේ බර ගැන ගොඩක් සැලකිලිමත් වුණා. බර වැඩි අඩු කරගන්න කියලා අපිට මේ ව්‍යායාම කරලා පටන් ගන්න කියලා කිව්වා. ආහාර වේල වලට මොනවද පාවිච්චි කරන්න කියලා ඇහුවා. විශේෂයෙන්ම තෙල් වර්ග ඒවා ගොඩක් අඩු කරගෙන ජීවන රටාව හදාගන්න කියලා කිව්වා. ඒ වගේම අපේ ගෙදර අයටත් දැනුවත් කරා. ඔයාගේ මේ මහත්තයාට දැන් අවුරුදු 52යි. හැබැයි ඔයගොල්ලන් දවරු දෙන්නෙක් ඉන්නවා. මේ ගැන කල්පනා කරලා බලලා මේ ක්ලිනික් එක හරියටම කරගෙන යන්න කියලා මට දැනුම් දුන්නා.
So since he was recruited into the study, the public health midwives have already advised him on the lifestyle. Not only him, his family as well, and advised him on the diet, the physical activity, and asked him to reduce weight, control his diet, and he had been discuss his social situation with 2 children, if he is ill, the consequences, and he has been advised on those things and maybe strengthened his compliance through that advice.
ඉදිරියටත් මේ ප්‍රෝග්‍රෑම් එකේදී සෞඛ්‍ය වෛද්‍ය නිලධාරිනිය අපිට ගමට එවනවා නම් අපිට මේක අමතක නොකර මේ බෙහෙත කරගෙනම යන්න පුළුවන්. එතකොට තවත් අය දැනුවත් වෙයි කියලා මම බලාපොරොත්තු වෙනවා.
The major thing he sees is that this program will improve patients regarding their compliance because of this frequent visits to the house and reminding about the need to control hypertension. So that's a real benefit to the patients to be on the drugs and maintain compliance and control their blood pressure. Do you have anything specific to ask him?
I'd like to ask him if he can say something about how the community generally feels about this program.
ඉතාමත් සන්තෝෂ වුණා. කියන අපේ ගමන නොදියුණු ගමක් ගොඩක් අධ්‍යාපනය අතින් අඩු කට්ටියක් තමයි වැඩිපුරම ඉන්නේ. රජයේ සේවකයෝ හරිම අඩුයි. ඒ අතින් බැලුවම ගොඩක් ඒ දීවර ගම්මානයක්. ඒ දීවර ගම්මානේ කට්ටිය ගොඩක් උදේ වැට්ට ගිහලා සමහරට මාසික එකමාරකට සැරයක් තමයි ගෙවල් වලට එන්නේ. ඒ වගේම ගොඩක් අය පිටරට සේවය කරනවා. ඒතකොට තරුණ කට්ටිය කියන්නේ දෙමාපියෝ බලා ගන්න ඉන්න කට්ටිය ගොඩක් අය රටේ ඉන්නේ. අන්තිමට මුණුබුරා සහ අම්මලා තාත්තලා තමයි වැඩිපුර ගෙදර ඉන්නේ. ඉතින් ඒ කට්ටියට සහනයක් වෙනවා. මේ අපේ සෞඛ්‍ය නිලධාරිනිය ඇවිල්ලා ඒ දැනුවත් භාවය ලබා දුන්නොත් යොමු කරොත් ළඟම තියෙන වෛද්‍යවරයා ගාවට ඒක අපේ යහපතක් කියලා හිතනවා.
His villages are underdeveloped. It's a fishing village mainly, and a lot of people are going to sea, and they might not be at home for like long periods, like 1.5 months. And the other general situation in the community is that a lot of people are working overseas, and there are a lot of elderly as well as younger families living in Sri Lanka while the breadwinners are overseas. So in that situation, he feels that the visits of the public health midwife and the continuous monitoring and support and advice is really facilitative for controlling blood pressure and also managing the other risk factors. So he thinks this is a great benefit to the community.
I think Aliya has a question, and then Jehan, and then I think we're going to have to wind up after that. It's 1 o'clock already. Use the microphone. Oh.
Yeah.
There's one behind you. Look behind you.
Oh, no, thank you, and it's wonderful. My question is to you, gentlemen, that lifestyle modification, like being active and quitting smoking, is one of the 2 important advice for COBRA. And third one is diet, healthy diet. So we advise them at home level, but I'm really interested to know whether this gentleman, or to his experience, other colleagues, have been able to adopt that, and did they see any change in their weight or activity?
ඔව් ඇත්තටම මම මේ වසර 2කට 3කදී කට ඒ මේක පටන් ගත්තට පස්සේ මගේ බර තිබුණා ඇත්තම කියනවා නම් කිලෝ 86ක්. හරි මම මේක වර්ෂ 3 ඇතුළත කිලෝ 74ට මම බර අඩු කරගත්තා. ඒ වගේම ඒකත් එක්කම මම ගොඩක් ආහාර කෑම ගන්න එක ගොඩක් අඩු කරනවා කියන්නේ මම ගොඩක් පත්තෙම පළතුරු තිබුණා. ඒ පළතුරු කන්න පුරුදු වුණා අපි. කෑම වෙලත් එක්කම ඒක ආහාරය අඩු කරලා පළතුරු අරගෙන ඒ වේල සරි කරගෙන හිටියා. ඒ වගේම මේ ඒකදී මම බර අඩු වෙනවා කියලා දැක්ක හින්දා මගේ ව්‍යායාමය මම දිගටම කරගෙන ගියා. මම දැන්ටත් උදේට නැගිටලා පොඩ්ඩක් ඇවිදිනවා. ඉතින් ව්‍යායාමය මට හොඳ බලපෑමක් වුණා කියලා මම හිතනවා.
He reports some success, especially regarding the weight reduction. He had been about 12 kilos more than this at that time initially. So the emphasis had been on improving exercise, controlling the diet, and also cutting down on the dinner. So he had been able to adhere to some of them to some extent and had been able to successfully reduce weight. So he thinks it's affecting the other people also positively like that. Even now he does physical activity like a walk in the morning.
Very short, nasty question. You know you are participating in a study that is called COBRA. COBRA is a very dangerous snake. Does that play a role for you? Were you not afraid to join the study?
ස්ටඩි එකට කලින් තමයි මම මේක දැනගෙන හිටියේ නෑ. මේක ලොකු විශාල දෙයක් කියලා මට ඇත්තටම මේක මේ පෞල් සෞඛ්‍ය සේවිකාව තමයි දැනුවත් කරේ. මගේ ඒජ් එකත් එක්කම මේකට හදිසියෙ මට බලපෑමක් වුණොත් එතකොට තමයි කොබ්‍රා එන්නේ කියලා තමයි කිව්වේ.
Actually, I don't think the patients know the study so much as COBRA in Sri Lanka. But actually, he has been told that the COBRA will strike him if he doesn't do the...
I hope they do know they're in a study. Shanti, sort of last word before Shah will wrap up.
No, not the last word. I just want to clarify something. I have a habit of saying very openly what I believe in and sometimes getting into trouble. Now, I don't want people to go away thinking COBRA is not a good study. It is a good study. All I'm saying is when COBRA is being expanded, you need to take the reality into account and cost effectiveness, affordability, and sustainability into account, because that is where you can translate what you find into policy. And to take that into consideration when you are expanding, that's all I'm saying. So, and the second short statement is, I don't want to answer to this, is to the funding agencies and development agencies. They keep financing single vertical programs. With due respect to the MRC and all the funding agencies and all the development agencies, I don't know why they do that. They do the same mistake that they did with communicable diseases. Thank you.
Here. I hope Jill's heard that. Wave, Jill, if you agree. Yes, she agrees. Good. Okay, now Susie wants to say something. We're not doing very well here. We're trying to close up.
Yeah.
After time.
No, I just want to say that when Sri Lanka is looking at this integration, we are actually doing a cross-programmatic efficiency analysis. So that will really tell us how to really integrate. We are looking at, changing this vertical thinking and putting it into the primary care system. Yeah.
Thanks. Charlotte.
Okay, fine. Just a few words. It was gratifying to hear the words mental health mentioned for the first time this morning. And I think at our peril do we embark on a raft of NCD work without including mental health. They are our allies in this. I think the other thing that I wanted to say I've just forgotten, so I will shut up now.
That's the advantage of age.
It is, absolutely. It's not come back. So I think all I'm going to do now is ask Kazmi to come up and say a formal goodbye to people. That's what you're going to do? And a seater as well. Thank you.
So, no, I'd like to thank everyone, all the people who've traveled, or the people who've come here, all the stakeholders, our moderators, and chairpersons and speakers, the COBRA team, the funders, everyone for sharing your views. I think this has been a great session. I think for the COBRA team, I think for us, for moving forward, as we analyze our results for the current study, thinking about it for our strategies, how we're going to move forward, this has been very, very helpful and invaluable. And as we are thinking about scaling up and our next steps, I think the discussions on, and I take all these points that have been mentioned about, when we are starting about a single strategy and we are talking about, although the focus is, I have to say and respond to in the thank, I'm going to also offer a response here, that although we are thinking about, this is more than hypertension, we are really thinking about whole of vascular risk reduction here in this approach. Because and I think that's been repeatedly mentioned, that when these community health workers are going home, they're delivering a home health education, which is really about shared risk factor approach. And we have, although in the interest of time, we didn't really present a lot of the work that has really gone into COBRA, but we've published a lot of papers on how the blood pressure and the risk factor levels are, even in the children, were reduced with this approach. So there's a lot of extended benefits to the community. Sure enough, when we're producing scientific evidence, we want to look at clinically meaningful reductions. And I think that's when the battle of what you publish and what you don't publish and the scientific comes in. But the approaches are definitely very comprehensive. And when we started this, we said hypertension will only be the entry point, and we want to create a platform when the community health workers are not at the stage where you can go ahead and train them in every single thing. Then they become confused. So we do this in a stepwise manner, in a staged manner. We'll start with hypertension, we add diabetes, we add kidney disease, we add other conditions in a stepped approach. But I think our goal is, of course, a comprehensive NCD looking at all non-communicable diseases eventually, but of course a vascular risk reduction approach. So I take all these comments. I think these are great comments. And integration, this is all integration, all into the primary healthcare system. So I couldn't agree completely with that. So this has been, again, and I think all the stakeholders coming here, without your partnership, this program would not have been possible. Without government's partnership, this program, it would have, we've really moved forward because the community health workers governments participated with us in each and every country. We could not have moved forward without the physicians' cooperation and without the drugs being handled out by the ministry through your primary care system. So I think the cooperation is already there and it's already working because it's already integrated in part in the areas where we are working. So I think I think our site PIs realize that, and I would like to extend our thanks to everyone who's here and who's also not here and has been cooperating with us and with the team. So so I think with that, again, but the suggestions here are extremely, like I said, we will be taking them very, very seriously. We've made a note of them. The session's been recorded, and we will go over them. Again, we have a trial steering committee meeting this afternoon. We will discuss these key points there, and we will, again, modify our strategies as needed, and we will hopefully come back and share them with you and keep, for the Sri Lanka team, I think ASITA will keep you engaged in the National Advisory Committee and bring back these modifications and seek further input from you. So I think that's the way to move forward with the local committees and have parallel committees. We do have parallel committees in the other countries, but we will keep this process going, which is completely, extremely valuable for us. For the meeting, I would especially like to thank the local team here. Prof. Asita's team, I think, did a fabulous job. We've just had to come here. So thank you so much for organizing this and your cooperation with that, and for meeting all the excellent stakeholders here. It's been a pleasure, and hope to see you all again. And with special thanks to Ingrid and Chamini, who really did a lot of legwork for a very long time. It's taken us months to organize, so thank you. And from my own team, I would like to thank Cecile and Federico, who've been working with me, and Qingwei, and Feng Liang, and Saide, who's not here, but who's been working a lot on the COBRA team. So these few people, I would just like to say, extend a comment. So thank you so much. Thank you. Asita.
Thank you. As your host this morning and the afternoon, thank you very much for your time. I deeply appreciate that. I know a lot of you have very pressing commitments to meet. Clinicians are here, their cath labs have stopped. Of course, there are other people doing that work. Dialysis machines are idling right now. But thank you very much. It's deeply appreciated. And at a personal level, I'd like to thank Susie, Dr. Susie Pereira, DDG of Public Primary Healthcare Service in Sri Lanka. She knows the system backwards. She's one of the authors of this newly jigged up primary healthcare system, conversion that we are talking about. Deepika, Attygalle, and her team from World Bank. And Dr. Pramita from the RDHS, Regional Director of Health Service, Butlam District, was a live wire to make this possible for us to run COBRA and still run COBRA in the long-term follow-up. So thank everybody, my team included, for being here and making this a very valuable discussion.